tell you the prior important even in gynecological conditions also. So first few minutes we had to build a good rapport, good trustworthy relation with the patient. Then only the patient will speak about their menstrual irregularities or about their PID or any infections or discharge or something. They feel like the patient is accompanied by their husband or like mother-in-law or mother. Sometimes we feel that if the patient doesn't tell you the proper history clearly, then try to maintain a private space between the patient and you. Then only they will sometimes tell, because when in an infertility patient, when the menstrual irregularities comes, so usually patient will come, yeah, only after marriage I am having this type of menstrual irregularities. So if we ask the patient regarding that in a private area, private space, or we give some privacy to the patient, irregularities, they do treatment, and again now the irregularity came. So in some cases we had to build a good rapport with the patient. Then only they will tell you more clearly about the gynecological related issues. And we had to be a good in a listening mode, or then only we can get all the relevant points regarding the condition. So just like that, in initial phase we had to collect the personal data, the age is important when dysmenorrhea type of complaints are more seen in then fibroid, irregular menstrual cycle, adenovirus, such type of cases are more common in the elder age ladies. And also marital status is important, because we can do only per vaginal examination only in a married lady, so marital status, occupation, regarding the stress is there or not, that we had to all assess. And what is the presenting complaint? So if she is having any menstrual irregularities there, so when did the cycles become irregular? So we had to start from the LMB, or start from the menarche itself. So after menarche, when the cycles become regular, when it become irregular, how much months does a cycle become irregular, whether she taken any treatment for that, all that thing we had to ask. And if it is she's having any dysmenorrhea, so when the dysmenorrhea started, or whether it started 2 to 3 days prior to menstruation, or whether the pain is there throughout the menstrual cycle, or if there is any vaginal discharge, is there any relation with the menstrual cycle? In some cases we can see just prior to the menstruation, this vaginal discharge condition become increased. So we can ask about the complaints and whether that it is related with the menstrual cycle, or how severe is the condition, that we can ask in history taking. And also regarding the maturation and all, regarding their bladder, most of the ladies may have a habit of recurrent urinary tract infection, especially in cases like PID, or even in cases like vaginal discharges and all. Is there an association with this type of recurrent UTI? That also we had to keep in mind. And also ask whether the lady is having, especially after the delivery, or in an elderly lady, if she is having any stress incontinence, whether in coughing or sneezing, whether the bout of urine is passed, like that we had to ask. And also about the bowel habits, about the constipation is there, or the blotting or flatulence is there, or ask for any abanovaigunia, we can ask for that. Then regarding the menstrual history, we had to ask from the age of menarche itself, whether the cycles appear normal, whether the menarche occurred normally, or whether it is induced or not. That also we had to ask. And also if we are looking for the regularity, even if the patient tell you that my cycles are regular, every month I got periods, like that, then also you ask about the menstrual period, especially the last menstrual period. Most of the patients may have app and all, so they will easily note the menstrual date, and also ask for the last 2 menstrual period. Then we will know whether the cycle is regular or not, and ask for the length of the bleeding, that is whether how many days the bleeding is, it's about 5 days or 4 days or 7 days, and whether there is a proper bleeding is there any clot is there, or is there any color difference or any smell difference. That all thing we had to ask clearly. Or if there is any pain associated during the menstruation cycle, or if there is clot or even like membrane type of like such type of membranes are seen or not, like all these things we can ask. Or sometimes the patient may have like spotting in between, like the spotting starts 2 or 3 days prior to menstruation, and even after menstruation 5 or 6 days there will be spotting. So that also we can ask. And in some patients we can see like post-coital, after a sexual contact they have like spotting or bleeding. Or sometimes the patient may like in after doing a heavy exercise or traveling and all, they have some spotting and bleeding. Such type of presentation is there or not, we can ask for. And also if the patient complains of there is pain in the or dysmenorrhea, or if a secondary type of pain is there, then we had to ask for the location. Where is the pain? Is it in the lower abdomen, or is it in the right or left iliac fossa? We had to clearly ask where the pain is. And also, is there any pain like the radiating type of pain is there, or is the pain related to menstrual cycle? Or even some ladies have like chronic pelvic pain. Throughout the cycles they are having pain and like vague aching type of pain. Sometimes in endometriosis or sometimes in PID, such type of presentation will be there. Especially during the periods they are having like severe pain. After that the pain will be mild, but throughout the cycle they are having aching type of pain. So we had to clearly collect all the details regarding that. And then we had to ask about the obstetrical history, whether the lady had delivered number of children, whether abortion is there. If abortion goes, then whether there's a D&C, or like that if some patients who are having like 2 or 3 D&C is there in their like in the perimenopausal period, there's an increased risk of prolapses there. So such things we had to keep in mind. And also if the patient is having any abnormal vaginal discharges there, so we had to ask them whether it is having any relation to menstrual cycle, or what is the color, like it is like a mucus type of discharge is there, or like a milky type of discharge, or like a curd type of discharge. So depending upon the color of discharge, or if it is like an yellowish greenish type of discharge, so yellowish green, that means there is some infection, no? If it is like a Cordyceps candida type of infection, so with the color, consistency, or if associated symptoms like if the odor is there or itching is there, then we can come to a conclusion or to a diagnosis. It will help us. Or also we can do an examination in such type of patients if they complains about this vaginal discharge. Sometimes we can see if the patient is there having mild discharges there. But when we are doing a speculum examination, we can see that there is severe infection in the cervix or in the upper vagina, right? So even a patient complains of discharge, try to do a per speculum examination if possible. And also ask patient about a family history of diabetes, hypertension. So diabetes, if in a patient of PCOS with a family history of diabetes, then we can suspect the patient is like a pre-diabetic or insulin resistant state. So along with the PCOS medicine, we had to give medicine to that condition also, like in a pre-diabetic or insulin resistance. Then only our treatment will get a very good result. And also if the lady is sexually active, so we had to ask about whether there is any dyspareunia is there. Dyspareunia means pain during sexual contact. And also we had to ask whether it is a superficial or deep dyspareunia. Superficial means around the opening of vagina if there is pain, or something. Deep means inside on the upper vaginal area they are having pain. So deep dyspareunia usually occurs in the pelvic inflammatory disease, especially in a severe type of vaginal infection, vaginal cervical infection. They are having this deep dyspareunia, or even cases with endometriosis, they are having this dyspareunia. And sometimes if some patients tell that even after a sexual contact, their vaginal infection just increases. That is also type of clinical presentation for chlamydial infection or bacterial vaginas also. Such type of presentation we will get. So that also we had to ask about the past treatment history regarding the dysmenorrhea. Or some patients may have this laparoscopic correction for they have like an endometriosis, or if the cyst is there, chocolate cyst, or even the clear cyst is there, any cystectomy done, or any treatment for PCOS, or any adhesional lysis treatment. So we had to ask for any past treatment history regarding this. And also thyroid related issues are commonly seen in reproductive English ladies. So thyroid related, if they are taking any thyroid medicines, or also that also we had to keep in mind if they're having any. Or also if the lady is planning to conceive, then also we had to, it's mandatory to check the thyroid level. And also when we are talking to the patient for like past 10 to 15 minutes, when we are taking the proper history, we will get a very good idea about the psychological status of the patient. So the psychological status of the patient is also very important, because in some cases, especially in dysmenorrhea, pain is a subjective symptom. No, so if the patient is having a good sattva, so then the patient may sometimes present that as even only a mild presentation or mild symptom. So if a sattva is like avara sattu, then even with a mild pain, they will present it as a very big symptom. So the psychological status of the patient should be also assessed when we are taking the history. Along with the history, we had to also do a physical examination, especially if a lady complains of abdominal pain, or just do a physical examination, just do an abdominal palpation. Sometimes we can, if there is some like pelvic any mass or something like that, we can easily feel the pelvic mass. Or even if the lady is not in a menstruating phase, we can do a per speculum or a bimanual examination to get into a proper diagnosis. But or if speculum examination is not done, then also try to do just an abdominal palpation to see whether there is any pain or tenderness in both iliac fossa, that is lower abdomen is there, the area below the umbilicus is the lower abdominal area, and just to side of it is the right and left iliac fossa. If there is any pain or tenderness in the iliac fossa, we can suspect there may be any like any PID or any cyst or like endometrial adhesion will be there. Like that, we can just differentiate. So for getting a better conclusion, we can use the help of the investigations. Like commonly, we can do an ultrasonography. You can do an transvaginal ultrasonography if the lady is married. And transvaginal ultrasonography will get a very good idea about the ovarian condition. So if we want to we want to get an idea about the ovarian condition, it's better to do a transvaginal sonography. Otherwise, we can opt for a transabdominal sonography. And also, if the patient is not able to do a USG, then we can also do a bimanual examination to see whether the uterus is normal, or if it is a lean patient, we can easily palpate the ovary, the fallopian tube, and also we can easily palpate if the patient is very lean. So if you're doing it regularly, then you can master it. Next is the female, as we all know, the female reproductive system. So some of the most common conditions that are related to the female reproductive system is like if related to the endometrial, this is endometrial layer. So if the endometrial thickness is more than 8 millimeter, especially the normal thickness is 8 millimeter, if it is more than 10 or 12, then this endometrial hypoplasia. Or if some fibroid which encroaches into the cavity. So the submucosal fibroid will also increases the bleeding. Or sometimes the fibroid is seen in the muscular layer, intramuscular layer. Then also adenomyosis, which are the common conditions related to uterus. And related to ovary, we will get common conditions like PCOS or chocolate cyst or even simple cyst in the ovary. And or sometimes we'll get cases like there is infections in the fallopian tube related to the pelvic inflammatory condition, or even the hydrosalpinx, that fluid filled in the tube, or regarding the endometriosis. Along with the endometriosis, the tube may be occluded, and the endometrial implants may be seen in the tube. And sometimes in the cervix, we can see cervicitis, the infection of the cervix will be seen, or there may be infections in the vagina. It can be a candidal bacterial vaginosis type of infections in the vagina. These are the common cases that we get in our OPD, like dysmenorrhea, PCOD, endometriosis, sometimes heavy bleeding. So heavy bleeding, it can be due to endometrial hyperplasia, or even due to fibroid, or discharges we will get, fibroid we will get. These are some of the common cases that we generally get in our OPD. So we will start from dysmenorrhea. Dysmenorrhea, the term itself is like painful menstruation, just like we can say it like kashtartha. It's a symptom only, no? So sometimes there may be an underlying pathology. Sometimes it can be simply a functional defect only. So we can classify dysmenorrhea under Kashtartham, Vajayuni, etc. So it is the most common gynecological complaint that we get in our OPD. As we had already said, it is like a pain is like a subjective symptom. So sometimes a patient may have may present it in a more severe form. So usually younger age women, especially like 15 to 24 age, they have more chance of primary dysmenorrhea. But we also had to keep in mind, even in younger age lady, we can get cases like endometriosis or chocolates like that cases also. Even in younger age we can get. Or these ladies may be a potent, like they may have or they are in a higher risk category to develop such secondary type of dysmenorrhea. So that also we had to keep in mind. Even sometimes we if we are doing an ultrasonography, if we are doing a clinical evaluation, if we don't find any secondary causes also, if the patient is having severe dysmenorrhea, so we are also responsible to prevent the secondary pathologies. So dysmenorrhea, we know that the monthly pain, it affects the normal, their day-to-day activities, it affects their productivity, or it increases the work abstinence. So most of the patients are having they are like fed up with the pain and they come to. So dysmenorrhea may be a primary and secondary. Primary means due to like the functional defect only, like the intrinsic factors. So secondary dysmenorrhea means it can be due to so many factors, like it can be due to endometriosis, it can be due to any pelvic inflammatory disease, fibroid, or any secondary cause like irritable bowel syndrome, any recurrent UTI, or mullary duct anomaly, or intrauterine contraceptive devices. So there are so many causes which may contribute to secondary dysmenorrhea. So when a patient complains about the pain, so first you had to analyze the characteristics of pain. Like usually in a primary dysmenorrhea, there will be a vague aching type of pain, and it usually the pain will start like 2 to 3 hours prior to menstruation, and even the pain may last through 1 day. But if the pain lasts for more than like 2 or 3 days, or throughout the menstruation, or sometimes the pain start like 2 to 3 days prior to menstruation, or even pain lasts throughout the cycle, or even after that the pain gradually subsides. So such things we had to ask the patient. And also the associated symptoms, if the patient is having like vomiting or something, some like back pain, or like the PMS related symptoms is there, or if they're having any like bilateral tenderness is there, dyspareunia is there, or associated symptoms also we had to ask, which will help us to get into a diagnosis. So usually the pain will be especially in the hypogastric area, like a big type of pain, usually in the primary dysmenorrhea, and sometimes the pain may be in the lower abdomen, and especially and also in the back. Hello?
Madam,
Am I audible?
There is a small disturbance in your voice, ma'am. Hello, madam?
Okay. Is it clear now?
It is clear now. Sometimes it is coming.
Doctor?
Small disturbance coming.
Is it clear, doctor? Shall I continue?
Yes, ma'am. You can continue.
Shall I continue, doctor?
Yes, ma'am. You can continue.
Okay, the pain is there in the lower abdomen, and sometimes the patient is having like low back pain will be there, and sometimes the patient may complain if there is pain in the right or left iliac fossa. So these are the right of left iliac fossa. If the iliac fossa pain or tenderness is there, you had to suspect some underlying cause. Either it can be due to an ovarian pathology or like a tubal cause will be there. And if it is the right side, we had to always exclude appendicitis also we had to exclude. So the area of the pain, the like the intensity of the pain, all we had to ask for to exclude our diagnosis. So usually like in the primary dysmenorrhea and the spasmodic dysmenorrhea, the pain will be like a colic pain. And sometimes we can see, especially in the students or teenagers, we can see the psychological dysmenorrhea, especially related to exam time and all, and or even if some work related like pain and all. Especially the patient tell you that I'm having this minor type of pain for past 2-3 months. Then we had also try exclude the psychological and stress related dysmenorrhea. Also, we had really like mentally unstable or due to any like family related issue will be there or any work related stress will be there, which all contributed to the psychological or stress related dysmenorrhea, which reduces the pain tolerance limits. There, that's why they may present it as like a severe symptom. And usually the patient will try like hot water bag, and sometimes they will try with the pressure related like therapy. And even some patients like this ginger, which is having a very wonderful effect. It act like a non-steroidal anti-inflammatory drug like the cyclopam. So it reduces, studies are there, it reduces the prostaglandin secretion, thereby reducing the pain and all. So in modern they usually give the cyclopam related or the prostaglandin synthetase inhibitors they usually give. And in the Ayurvedic point of view, we can consider under the Shulam. As we all know, there is a role of Vadam, and we can see that the Vada Prakriti patients or Vada Pitta Prakriti patients, we can see they're having more of this pain related issues, especially this dysmenorrhea and all. They are having more seen in Vada Prakriti or Vada Pitta Prakriti subjects. If there is a Kaba Anubandham, the pain tolerance, the pain level will be much less. And we can see this dysmenorrhea as a clinical sign in various yoni like Vadagi, Sanivadagi, Paripluda, Udavartni, Andarmudi. So always try to exclude any secondary cause. So some of the common medicines which we can give in this primary dysmenorrhea like Gandharvastadi Kashayam, Hingojadi, Vaishwanaram, Saptasaram with Hingojadi, which we can give like throughout the cycle, or even in an emergency, if the patient is having severe pain and who come to you, then you can give immediately like a cyclopam effect. You can give Amritarshan, Punarnavasam, Vetumaran tablet as an emergency pain relieving medicine. And also you can give like Abhayarishtam, Dhanundram tablet combination, or Sugumaram Kashayam with Mr. Sneham, or Dashamula Shira Kashayam. If we are giving Dashamula Shira Kashayam, especially the patient with Vata Prakriti, for 3 consecutive months, the pain will be reduced dramatically. Dhanimadikritam we can give, Dhanundram Kashayam, Dhanundram Gulika, Avagaham we can give, Ashogashtam we can give. So these are the common medicines we can give. And also we can give like Matra. We can advise Matravasti, especially 10 days prior to the next cycle. Matravasti we can give with Mahanayarana Thailam or Dhanundran Thailam. Even 60 ml has a very good effect. Matravasti gives which we can give like 10 days prior to the next cycle. It has a very good effect. And also we can advise the patient some yogas like Bhujangasanam, Matsyasanam, Vajrasanam, Dhanurasanam, Surya Namaskaram, Shavasanam. Advise the patient to practice this like 10 days prior to menstruation, which reduce the pelvic congestion, and the patient may have much better results. Next is the polycystic ovarian disease. Polycystic ovarian disease is also known as teen Leventhal syndrome. Sometimes, when the patient is doing an ultrasonographically, they may come to you with a teen Leventhal syndrome. Some labs will send the report like teen Leventhal syndrome only. So PCOS is also one of the most common affected case. Almost 160 million women are suffering worldwide. Even it is a lifespan disorder. Even we feel that after menopause there is no issue regarding PCOS, but even after menopause, the consequences of the PCOS, that will be an increased risk of developing diabetes mellitus, hypertension, even cardiovascular disorders, and even endometrial CA is also common in PCOS subjects. So if we are like, even after menopause also, if we are like following the proper diet and lifestyle, we can advise the patient to follow proper diet and lifestyle in order after the menopause. So in the PCOS, we can see there is insulin resistance will be there, hyperinsulinemia. It's a metabolic disorder, but it is having a strong gene regarding the PCOS. Usually, they will come to you regarding the menstrual irregularity. That is the most common presentation that they will get there. They will come to you like 2 months, 3 months. They're having an absence of menstruation. That may be the common presentation, or sometimes come to you with regarding infertility issue, or sometimes come to reduce weight, or even the cosmetic issues, especially hirsutism or pigmentation over the neck and all, they come to you. So these are the common clinical presentation we will get. So some patients will come to you with an ultrasonographically says that they are having this bilateral polycystic pattern as mentioned in the report. So I'm having PCOS. Give some medicine like that, they will come. But if when a patient comes to you with this type of report, so out of the 3 symptoms, if the patient is having only 2 symptoms, then only we can consider it under PCOS. So she should have like irregular cycles, clinical hyperandrogenism, and even also if the PCOS, the ovarian volume should be more than 10 cc. Okay, so usually 6 to 9 cc of the ovarian volume. So the normal ovarian volume is 6 to 9 cc. If it is more than 10 cc, you can also see patients within 20 or 22 cc patients volume of the ovary. You can see. In some cases, the lab may not give the volume in cc. They will give only a measurement. So if the measurement is given like this, 3 into 2 into 2.2 centimeter only, then you can find ovarian volume by multiply it with 0.5. Then you will get the ovarian volume. So polycystic pattern or polyfollicular pattern means periphery. We all know periphery arranged follicles. The follicular size should be less than 9 millimeter. So it is the periphery arranged follicles. So these follicles are like, they are healthy follicles, but without the proper FSH hormone, follicular stimulating hormone, these follicles are like in this, like the semi-developed stage. So PCOS is even it's a lifestyle disorder we are considering, but it has a strong family history. Sometimes you can see very obese ladies, like they are about 90 kilos and all, without any PCOS, without any menstrual irregularities, you can see. So there is a strong family history. There is a strong family history regarding the insulin metabolism. Okay, the glucose metabolism. So insulin resistance is a major cause. So if the lady is having any family history of diabetes and all, if her lifestyle is like sedentary lifestyle and she take more junk foods and all, obesity is like that, she's obese, then there is a high risk of developing PCOS. So usually we can see most 30 to 70% of PCOS are obese, that we are having high BMI. So initially this fat tissue are having a capacity to convert the estrogen. There is a peripheral conversion of estrogen. So this estrogen will send a negative feedback. So FSH will not be produced properly. So the balance between FSH and LH is altered. So there will not be ovulation, will not be occur. And all the cause, all the pathology start from here, from the pancreas. So our treatment also aim at this area. So when the patient is taking more glucose or more carbohydrate or more sugar diet, so then there will be a more glucose in the body. So the insulin, there will be more insulin will be produced, but this insulin, there is an insulin resistance is developing. So this insulin resistance is developing. So the pancreas is forced to produce more insulin. So there is a hyperinsulinemic environment. So this hyperinsulinemic environment will always favor there is an increased production of testosterone and low sex hormone binding globulin will be produced. So this low sex hormone binding globulin will be there now. So there will be more free androgen or more free testosterone will be there. So these testosterone, this hyperandrogenic environment will not favor ovulation. So ovulation will be hampered, and this FSH-LH ratio will be also hampered by the estrogen hormone. So the negative feedback will get there. So our treatment should be aimed at these two levels. We usually give medicines to correct the ovarian volume, to correct the ovarian function, and all. But we had also to get a better result. We had to start medicine from these two levels. So first we had to advise the patient to cut excess sugar, excess carb and all. Though then the and also advise the patient to do very good exercise, especially a good cardio and like 30 to 40 minutes good cardio. So exercise will reduce the insulin resistance. So the main pathology is like it is solved. Then we had to give medicine to support the proper liver function. Then proper sex hormone binding globulin will be production will be corrected. So we had to give medicines to correct the liver function. We can give Arogya Vardhani, we can give Padavaladi and all. And for correcting insulin resistance, we had to advise the patient to correct insulin resistance. Like in a pre-diabetic stage, we can give like the Nishagata Kashayam and all, along with the medicines to correct the ovarian function. So then we will get a better result in managing PCOS. So usually we will get so many type of PCOS patient. Like sometimes the patient may have all the three symptoms. They are having like hyperandrogenism, like they are having excess hair growth on their face, their cycles is irregular. When you are doing ultrasonographically, the ovarian volume is high. So all the three symptoms are there. So they are classified into phenotype A or frank PCOS. Sometimes when allopathy doctors they like when the patient comes with you the prescription, you can see frank PCOS. They will written like that. So if all the three symptoms, the hyperandrogenism and ovulatory dysfunction is there, then it is phenotype B. Like that, we can see so many variety of PCOS patients, sometimes lean, sometimes obese, sometimes with all the three presentations. So depending upon that, the Rotterdam's criteria is mentioned this type of phenotypes in PCOS. So hyperandrogenism means there is excess androgen production in the body. As a result of this excess androgen production, certain clinical pictures we can easily get. One is hirsutism. Hirsutism, we all know there is excess hair growth in specific areas. So if in specific areas only, like if there is hair or if like male pattern of hair all over the body, then it can't be considered under hirsutism. So hirsutism means a specific like a conversion of terminal hair to vellus hair in these specific 9 areas. Then only we can consider it under hirsutism. So usually this pilosebaceous unit, that is this hair follicle, no. So they are very much sensitive to the androgen level. So when the excess androgen is there, so the normal hair gets converted, it gets more pigmented, it gets more thick and all. It is completely converted into this new like thickened hair. Next is insulin resistance. Insulin resistance we had discussed now. So the body, even the cells are not taking up the proper insulin. So they are not like accepting it as insulin. Like that we can say. So if insulin is not like if it is not utilized by the cells, so then there will be more glucose will be there. So it will be more deposited in the liver and all, and also in the it will converted into fat cells. So obesity may result. So even the PCOS, if we are advised the patient to reduce weight, they find it very difficult to lose weight because the mechanism is already like altered. So it is somewhat a difficult task for them to lose weight. Along with medicines, we advise proper exercise and all, it will be easier for them to reduce. And also in every PCOS patient, try to do a fasting blood sugar level. So if and also do an HbA1c level also to see whether the how the insulin resistance is there in the patient. So acanthosis nigricans also, sometimes we can see the patient, we can see the pigmentation of the on their neck and all. We can see that the patient is having this acanthosis nigricans, no, the pigmentation over the neck area, sometimes on the axillary region, sometimes on the like the folding area of the arm or in the popliteal fossa and all. Very much pigmentation, dark, velvety type of skin. This is a visible manifestation of this insulin resistance. So either the patient may be in a pre-diabetic state or the patient may be in diabetic state. So along with the like Prameha Aushadhi, along with the PCOS management, we had to give Prameha Aushadhi to control this condition. So usually the patient may come to you with menstrual irregularity. Sometimes the patient may have like amenorrhea for like 2 to 3 months, or sometimes they may have cycle, or some patient may have like medicines to induce the menstrual bleeding and all. Or if menstruation occurs due to less unopposed estrogen, because there is no ovulation, no, so the progesterone is not there. So because of this unopposed estrogen is there, so the endometrial thickness becomes so thick, so the patient is having like severe bleeding. When menstruation, of course, there will be severe bleeding will be there. And also we can see some patients even like 2 to 3 months of amenorrhea. If their menstruation occurs, there will be spotting only. Such type of cases also we can see. So there is some difference in each and every patient. So we have to understand the condition of that particular patient, then we can give the medicine. So in this PCOS patient, because of, as we had discussed now, because of the altered FSH and LH value, proper ovulation is not taking place. So a lack of ovulation or even infertility issues we can see. So in some lean PCOS patients, we can see PCOS with in a lean patient. So in that case, we can say that it's purely a genetic factor, maybe reason. So in such cases also, we can see compared to an obese patient, there will be less insulin resistance, there will be less this acanthosis nigricans or hirsutism and all. The obese PCOS, they are having more this menstrual irregularities, hyperandrogenism, and also they are having more acanthosis issues. And so compared to lean PCOS, the clinical presentation is more even in obese PCOS. So investigation we had, as we all know, the body mass index, HbA1c and AMH. AMH level will be much higher in PCOS patient. It will be more than 6 or 8, something like that. We can see normally it is like 2 to 4 is normal, but in patients with PCOS, the AMH level will be much higher. So along with our medication, we had to properly correct the diet and lifestyle. Then only the insulin resistance and the liver function will be corrected. Then only our medicines will act properly. Especially when the insulin resistance is reduced only, then only the liver function will correct. Then only our medicines will act at the level of the ovary. So if the patient come to you with like the patient is having like absence of menstruation, so our first aim is to induce menstruation. So if the endometrial thickness is correct, so endometrial thickness should be minimum 8 millimeter, no? So if the endometrial thickness is correct, then we give medicines to induce menstruation, then menstruation will occur. But if the thickness is less, if the thickness is like 4 or 5 millimeter, then we don't give this treatment to induce menstruation. First to give medicine to correct the endometrial thickness, then give medicines to induce menstruation. So to induce a cycle, we can give some Agneya Drivya, like Agneya Drivya also, which are having an anulomana property. Like we can, if it is a mild PCOS, and then we can give Saptasaran Kashayam with Hingvajadi or like that we can give. Or we can, if it is like a little bit more, we can give Kanashadahwadi, then we can give Chitragranthyadi. So if the patient is like more Pitta Prakriti, please don't give Chitragranthyadi and all. And also we can give Tilak Kashayam. Tilak Padam, we can advise the patient to prepare at home also. And also, if not possible, we can advise the patient to buy some black sesame seed with this jaggery and a little bit of hingu, and advise the patient to grind it in a mixie and advise the patient to take 1 or 2. Then also will induce menstruation. And if the menstruation has started, just tell the patient to stop this medicine in order to prevent excess bleeding. Sometimes there is a high risk of developing heavy menstrual bleeding. So when the menstrual bleeding has started, advise the patient to stop taking this medicine. Sometimes the patient may continue this medicine throughout the menstrual cycle. So that also we had to advise the patient. We can give like Panchakolasam, Kumariasam, Abhayarishtamithanatharam Gulika, Gandharvastadi Kashayam, all or even Kulatadi Kashayam, all have